Hey there, Ben.
Hey Steve, how are you?
I'm well. I'm well. Long time no see.
It's been a while.
Yes, it has. Well, welcome back, everybody, to Deep Blue Med Ed. We're happy to have you join us. Today, we're going to talk about a topic that Ben wanted to chat about, which is CPR, or the initiation of resuscitative efforts in the setting of this COVID-19 pandemic. Before we get started, though, I wanted to just, we did get some viewer mail. Scott C. from Derry, New Hampshire, wrote to us to tell us that our conversation was arousing. Not sure exactly what he means by that, but I consider it a compliment. And, judging by the two of us, I'm sure, I mean, we're irresistible, really.
He's only human.
He's only human. He's only human. I also wanted to give a shout out to a former classmate of mine from Pinkerton Academy, Stan Holinsky, who's an attorney here in Boston, who wants to do his part. He purchased a bunch of 3D printers, which to me is still kind of like magic. I don't understand the whole concept. But he got all these 3D printers, all these materials, and he's starting to make masks and visors for EMS and hospitals here in the Boston area to just do his part. So that's been fantastic. Fantastic.
That's great.
Ben, you have a shout out you want to give as well?
Yeah, just to the EMTs and paramedics out there doing the work throughout the state, throughout the country. It's very inspiring to see them coming to work, putting themselves in harm's way in a very difficult, persistent, sustained, and dangerous situation. And the dedication, teamwork, care for the patients, care for each other is inspiring, and it has my admiration.
Great, great. So, all right, today we're going to talk a little bit about resuscitation. Unfortunately, some of the patients that we see presenting to either EMS or in the hospital setting are coming to us in cardiac arrest. And now, some of those patients are non-COVID. They're the STEMIs or the arrhythmias. They're, some other cause of cardiac arrest. But many of these that we're seeing now are patients that have, had fevers. They've had cough. They've had increasing shortness of breath, and they're succumbing to the COVID-19 virus, either as a primary respiratory or cardiac event, or a combination of these factors. I think it's an important area to think about and to talk about. And I'm glad that you wanted to raise, or extend this conversation, because I think there's a lot to think about here, from not only, from both the EMS perspective, but also from the in-hospital perspective. I think that when we think about cardiac arrest and ACLS in particular, and where the genesis for that was that ACLS was the genesis for ACLS was for patients that sustained cardiac arrest in the pre-hospital environment, secondary to either an arrhythmia as a primary event, or myocardial infarction, or a combination of the two. And all of the things that we institute in that setting are to reverse those causes. So it's,
Yep.
good CPR, early airway management, defibrillation. And while we've been through many, many revolutions of different medications, I know when I was first a paramedic, the first medication we gave was sodium bicarbonate. And I believe that protocols have changed since then, where, yeah,
A little bit.
a little bit. We went through lidocaine, beryllium, amiodarone, vasopressin, et cetera, down to, now we're really just down to epinephrine as the only pharmacologic agent of interest. But that's really what the onus, that's really, what ACLS was developed around, was cardiac arrest in the setting of myocardial infarction and or arrhythmia. And I think now we've seen a lot of indication creep for starting CPR and doing ACLS. And there's certainly some circumstances where that's appropriate, drownings, overdoses, things of that nature. but many others where certainly this indication creep has just resulted in unnecessary procedures and unnecessary, resuscitative efforts. And unfortunately, I think we're going to find that, this is going to be another scenario where that indication creep is going to be causing more harm than good, and also
Mhm.
putting, people at risk. We
Oh
know
yeah.
that there's going to be certain risk with a lot of the procedures that we're going to be doing here. And, is that risk really, is there going to be a benefit from that risk? So Ben, I wanted you to take it from here. This was kind of your concept, your idea. What are your thoughts on, on resuscitative efforts during this COVID-19 pandemic?
Well, thanks, Steve. Well, first of all, certainly um, not my concept or idea. You're very generous. Like, I really wanted to pick your brain because Steve's on the front lines. He's actually working at the state's, and I think the country's first designated COVID hospital in the emergency room. So he's seeing these patients, and he works in the inner city in Boston. So I was really curious about what you're seeing because I work primarily in a planning administrative role, but also in the field, more in Metro Boston, kind of suburbia, some urban, but and we are certainly seeing an uptick in these calls and cardiac arrest calls and seriously ill patients. But one thing that's concerned me is trying to be ahead of the curve on planning as we look to see what's happening in New York City. We're a huge population base, about 10 million people, and extending into parts of New Jersey, northern New Jersey, and Long Island, with very dense areas now. Really, a lot of morbidity and mortality there, and a big surge in EMS and ED volume. So, what do we do as we shift from everyday to busy operations to an ongoing MCI at the highest level? What is our preparedness for that, for a plan to address patients that are in extremis and are in cardiac arrest, and what's appropriate, not just from an individual patient perspective, but also, like you were saying, what's futile and what isn't. And when we do futile things every day, it's probably not appropriate. But when we do them in a disaster, catastrophic disaster, and we're drawing down on resources that could be used for patients that have a chance, very sick patients that have even a slight chance of survival, that's probably not appropriate to be drawing down on resources for people that have no chance of survival or in a fetal situation, as well as, like you said, the really serious and real exposure risk to providers on scene, as well as then transporting a patient and then providers in the hospital when it's a futile situation.
No, those are all incredibly valid points. And so I wanted to first expand then on, you're integral to developing kind of the processes in and around, response to these calls and preparing your medic crews for these kind of calls. So what are some of the mechanics of, how you're preparing your crews to protect themselves in the setting where they're going to be going into a scene where there's maybe a potential for a COVID-19 patient? They're going to maybe initiate a resuscitative effort. What are some of the things that you've been instilling in them to do, both before they even get to the scene, but even then once they're there, and how they're going to be managing these cardiac arrests? What are the mechanics behind a resuscitative effort in that regard?
Well, some of it's counterintuitive, but the first thing is going to sound not in keeping with traditional response, but the first thing we're telling people is to go slow. Go slow is we need to drive carefully to these calls. We need to be preparing as a team for them. And we need to don our protective equipment in an organized, orderly fashion, following a checklist, using the buddy system, and always preferably with a trained observer for that process, donning and especially the doffing process, going slow. And by that I mean is that we're being deliberative. I don't mean that we're trying to in any way trying to delay providing care, but we're being deliberative and careful. I think the next step is really limiting the number of people to the least amount needed to execute the operation, whatever it is. whether we're just going to make contact with somebody, trying to have them come out if they can, but in a cardiac arrest situation, trying to limit that resuscitation team who has immediate contact with that patient to the least number of people needed to execute it effectively, and making sure that they're properly outfitted with N95, adequate face protection, face, not just eyes, but face protection, gown, gloves, of course, and that we're have good communication with that team, both amongst the actual caregivers, but also the support personnel that would be, kind of staged away a bit, so that they're not in the immediate kind of hot area with a potentially contaminated patient. And we're not going to know always, if this person, they're finding in New York City, a lot of the patients who they suspect have died of COVID aren't even on the radar screen with the healthcare system. They're dying at home prior to any medical contact.
Right. I remember when I started as a paramedic, one of the first pieces of gear I was issued was a leather jacket. I'm going to guess that's not going to be adequate protection in this situation.
No, you should give it to me. I'll take that.
Yeah, I just recently tried it on, and apparently I didn't know that leather shrinks so substantially over time, but
yeah, I can't find. I had a leather back in the days, and yeah,
I remember.
It's gone.
And there are a few other things I know that when we're thinking about resuscitation, certainly one thing would be airway management. That would be one area where I think many times, we're both big proponents of advanced airway management in the pre-hospital setting, but I think this is one of the few times where if you have a suspected COVID-19 patient, that deferring, direct laryngoscopy would be appropriate because of the risks. Video laryngoscopy, if it's available in the field, might be something to consider. I'm not a huge fan of supraglottic airways as a primary means of providing airway management in the pre-hospital setting, but I think this is one of the times where that might be an appropriate thing. The other is, we're adamant, and there's great evidence to support that one of the things that is probably most beneficial in resuscitation is really good compressions, but making sure that, that in the setting of the COVID-19 patient, where there's concern for respiratory aerosolization, that you do stop compressions when there's ever going to be anything that could put a provider at risk for aerosolization. So if they're going to be putting in an airway, or if they're going to be anywhere in and around the patient's head, to stop those compressions so that you're not, pushing secretions into the air. This is, counterintuitive to what we've been doing and what we've been teaching. And I don't want this to spread to all populations of cardiac arrest. There are going to be people that still drop because they had an arrhythmia, because they've had a STEMI, because they've had a PE. Yeah. You have to be careful not to, completely change ACLS, so that it's a detriment. But at least in this patient population, when you have a high suspicion, like you said, being very cautious, only sending in the number of people that need to be there, doing, donning PPE before initiating resuscitation, and really only doing those procedures that are necessary, and limiting kind of exposure risks are going to be, what are going to be most important here in that setting.
Yeah, agreed. It's a daunting prospect, because resuscitations by their very nature are very labor time and intensive in their close proximity operations. How do we effectively do this and at the same time try and stand off a bit or limit our contact? I think mechanical CPR might have a role with some of that. I think making sure obviously our PPE's on, and anecdotally you hear stories about people developing ad hoc barriers, like someone ripped down a shower curtain and kind of used that as an ad hoc barrier to kind of provide some, at least intuitively, logically, some space between themselves, while still being able to deliver chest compressions and manage the airway underneath it.
Yeah. So that brings me to another thought that you and I have both discussed, which is, are there going to be times where EMS is making a decision that they're not even going to initiate CPR, they're not going to initiate any resuscitative efforts at all? This is, again, something that there are some protocols in place for this when there's obvious death, rigor mortis or, severe trauma, things of that nature. But this is going to be, where there was some sort of precipitating illness, subsequent cardiac arrest, family calls, EMS shows up on scene. Where do you, what's your vision as far as, how can we facilitate making a decision about not initiating resuscitative efforts in the field when we know that this is likely not going to have a good outcome? This is not the STEMI, not the arrhythmia, but this is a progressive disease, and now you're at the end point of that disease. How do we facilitate this kind of process of not even initiating resuscitative efforts to both protect the providers, to protect the patient, and even to protect the families, because we know that there's going to be some risk, for initiating these kind of, resuscitative efforts in a home setting. What are your thoughts on, are we prepared for that? Do our EMS providers even have that training? Are there, protocols in place? What are your thoughts on how we can institute kind of a, do not resuscitate in the field without even having those do not resuscitate orders there?
Yeah, there are places that do that. You think back to, ordinary times just a few weeks or months ago where we weren't in this situation, but and the protocols we operate under, the standards we operate under, there are other systems that have more flexibility around this. I think what you're speaking to, Steve, is a really good point, just beyond COVID-19 pandemic, of the issue of medical futility in the emergency medicine arena, whether that's in the hospital or in the field. And I felt like some years ago we had made a lot of progress with this, and then it actually seems like we've regressed for a variety of reasons. I think the primary one is that we lack a real. We used to have a fairly regionalized EMS paramedic system, and not at all places, but most places in the Commonwealth, and that has devolved. So now it's decentralized, deconcentrated, and we're not able to, physicians aren't able to have the kind of rapport, control, and experiential trust that we used to have. So there's issues around that affect this as far as people's comfort level and their familiarity with making these decisions. The issue of medical futility, I mentioned to you in the past. A sociologist at Brandeis wrote a book on it, The Myth of CPR. It's a good book, and it points just to what you were saying, is that CPR was invented for people having a sudden, immediate, unexpected event, whether it's an MI or an arrhythmia or an asphyxiation or the like, something sudden, unexpected, and abrupt, that is deemed reversible, likely reversible, or even unlikely reversible, where it's human life. We're going to take long shots. That's what we do as paramedics. We take long shots to save life, and that's always reasonable and appropriate. But that is different. Taking a 1 in 1,000 chance to save someone's life is reasonable and appropriate. Taking a 1 in infinity chance, no chance, and there's a major risk to the providers, and there's a risk to the community at large in a catastrophe, that we're drawing down, depleting resources, both people and materiel, and straining it as far as capacity, then transporting people into settings that are needed to deal with viable patients. By viable, I mean even extremely ill patients that may end up dying, but still have a chance, however slim, still have a chance. But bringing people in who have no chance is not reasonable. It's not reasonable.
Yeah.
And it's not ethically reasonable. The bioethicists say, we have to do this and that. And I listen to that. But good bioethicists understand medical futility, and they agree with, the arguments to support not transporting and even not even initiating resuscitation in certain appropriate, clinically appropriate cases. And I agree with you.
Yeah, no, we obviously, feel the same, that there are many instances where you have to make a decision, not only as a clinician, but also as a human, and weigh the factors as to, what are we doing here? Are we causing more harm than good? And many times, like I've mentioned previously, we have indication creep for all of these things, and
Oh
resuscitative
yeah.
efforts are one of them. When you have a terminal event like we're seeing with COVID-19, these resuscitative efforts are not gonna, they're futile, and they're
They're not going to change things at the cellular level.
not going to change things. And while it's it's difficult for all of us, as from the
Terrible.
healthcare providers to the families, on up, we have to take a realistic look at the how we're benefiting that patient, because they are the most important piece of this. They've already been through enough. Are doing all of these things, is it causing more harm to that individual, to the families, to the providers? And then also looking, again, which it's unfortunate to say, but you also have to look at risk, and you have to look at resources in this setting.
Mm-hmm.
Yeah.
Yeah, that's just it, Steve, is that I couldn't agree with you more. And also the mindset change, as clinicians, we are trained to, not just technically or, professionally, but also morally, we're trained to, as well we should, really value human life at the individual level, and to treat each person with, maximal effort. And as we should. We always should do that and always have that mindset. However, in a disaster and in disaster medicine, there's a very difficult gear shift. And I work on training paramedics and EMTs to do this sort of thinking at car accidents, where we may have multiple injured persons, and some of them are in traumatic arrest, and some are critically injured, and some are moderately injured, and some have minor injuries, kind of a plurality of patients. Let's say that there's 10 at a multi-vehicle accident. And we still really struggle with getting paramedics and EMTs and first responders to understand that the patients in traumatic arrest are not the priority. And in this situation, we're looking at a population. We're looking at in Massachusetts, this is a level 6 mass casualty incident. This is a mass casualty incident, ongoing and pervasive and persistent in the country. And it's ongoing, stressing on all of our operations, and it's going to even more this week apparently, or most likely. And we need to shift to treating the population, and that's very difficult. And that's the saying that goes with MCI training, that pretty much any EMT or paramedic will know, and any emergency medicine physician or practitioner will know, is do the greatest good for the most people. And that is something we need to apply to this situation, or be ready to apply as the anticipated surge is upon us. For us to provide futile care in that scenario is, I would say, is unethical, not just to that individual, but to the population.
No, totally agree. Totally agree. We only have a few minutes left. So I wanted to talk about and get your thoughts on, there are some logistics, obviously, to deciding that you're not going to institute resuscitative efforts or to discontinue them on scene. That means that there's going to be, someone who is on scene who's died. We know that, law enforcement may be involved, the medical examiner's office, Department of Public Health, funeral services. There's also risk for family coming in contact with that individual who we now suspect may have expired from, a disease like COVID-19. What are your thoughts, and how are you guys handling kind of these, multiple logistical issues for that kind of process, where you're deciding we're not going to resuscitate, or we're going to discontinue resuscitative efforts? How are you guys dealing with that? What are your thoughts on some of the ways that EMS needs to think about, that process?
Well, fortunately, our medical director has been medical directors. We operate in two contiguous areas so we have two medical directors. One of them is kind of the primary. They've been very supportive of this as a just-in-time protocol and expanding that. In Massachusetts, it's protocol 6.11. I think I'm saying that right. I've been writing it all day. And it does allow for termination of resuscitation with medical control after 20 minutes of efforts on scene, and the person meets all the other criteria. They're not having any signs of viability or including, rhythms that are potentially viable, et cetera. But I think preparing for it and the coordination that you speak to is really key. And so we're trying to do communication on that. Doing it just in time is, I'll be honest, it's unfortunate because while we do it already ad hoc in unusual situations, sometimes we can't extricate somebody for whatever reason. It's in the area I work in, it's not as common as it is in other systems I've worked in. Like when I worked in New Jersey, we did it all the time. And I know Boston EMS does it frequently anyways, but in my system, not as much. And so now to turn that on and to acclimate the other entities, particularly the fire service, but also I think even more so law enforcement. And there's other issues there, tangential issues like the drawdown it may have on them, as far as time, resources, et cetera. And then you speak to the infection control issue of cross-contamination with grieving family members and all that coordination. So the complexity is robust. I don't claim I have all the answers at all. I don't. I think some of it is we need to be honest about that and also learn as we go, because it is a disaster, and have good communication. I'm trying to use and encouraging our team to use the debriefing model that I know you and certainly Dr. Prusty at St. E's has really championed with briefing critical cases, executing on them, and then really debriefing them carefully so we can glean those lessons learned of things maybe didn't go so well, and also take away best practices, things that did go well, and then share them in a way that's helpful and helps everyone improve. And that's going to be part of this too, including TOR, not just the care part, but the aftercare part for the survivors, as well as the rest of the team, as we, including the resuscitation team themselves, as they acclimate to this new reality.
Yeah, incredibly valid points, and a lot to think about. This is unprecedented. As with even with my background in disaster medicine and having come from a fellowship in disaster medicine, we see things like SARS and MERS and Ebola, and you never expected it to hit our turf.
No.
We've had the Boston Marathon bombings and we've had other disasters, but this is really unprecedented terrain. And I think my hope is that these are lessons learned that we carry forward, because this is going to be one of I fear many more issues of a similar nature to follow. And these are the things that we need to make sure we institute. And I use the term system lightly because I don't think we necessarily have a system, but we need maybe it's a call that we need to develop an EMS system, and we need to make sure that all of these things that we do rote, like cardiac arrest and trauma and anaphylaxis and abdominal pains, but it's really these other issues that we've tend to ignore, that really make a huge difference when we're dealing with these kind of with these major events. And my hope is that these are things that we can further develop. We can get a better understanding of how to make positive impacts on our EMS and healthcare system in general. These are trying times, but they're an opportunity to really make some changes for the better, to institute policies and protocols and practices, and better educate our professionals on how to manage these these really trying times. So Ben, I appreciate your time. as always, you bring great insight into these, really difficult topics. I always appreciate your thought process and your views. Let's hope that this is, I think, our third week of doing these online. Let's hope that in the coming weeks we can actually sit together for one of these soon, because the social isolation social isolation has been fun. I enjoy it. But it's starting to wear on me. It's starting to even wear on me a little bit. Yeah.
Yeah, it's certainly a difficult time for everyone, and like you said, I think in adversity there's opportunity for personal improvement and for strengthening and realizing what's important in our lives. Our family, our friends, loved ones, communities. And thinking about maybe what we should hope for, work for, and also what we should expect. Not expect in an entitled way, but what we should expect from ourselves, from each other, and also from our government and our communities, what we should expect, and is there a better way? There's a saying, and I'm not going to say it perfectly, but we're not going to arrive at the solutions for today's problems with yesterday's ideas.
Yeah.
While yesterday's ideas may offer some value, they may offer some value for us. They will, in some other things, we need to really be imaginative and think about, this needs to be debriefed when this is over.
Yeah. I would say that might be a good idea for us to debrief some of the things that have happened over the course of the last few weeks and weeks to come. Certainly.
All right. Well, I hope everyone stays safe. Wear your PPE. Be really careful on these cardiac arrest calls. Slow is smooth and smooth is fast. Use your PPE checklists. Use your buddy system. Limit the number of providers, even a cardiac arrest, to just what you need. Make sure, I think, Steve pointed out, I thought it was a good point, is when you're doing a cardiac arrest type call or anything with the airway or a lot of invasive stuff going on, wearing that full face shield, maybe in addition to goggles, is probably a really good idea, as well as your N95. But all the best to all of you.
Same. All right. Well, this is Deep Blue Med Ed. Ben, Steve, we'll see you next week. Thanks a lot, Ben.
Thanks, Steve. Take care, everyone.